Good morning. How's everybody doing? It's an honor to be asked to speak at this outstanding conference. It's a very important topic, very interesting topic. There's going to be a lot of questions, now and in the future to answer. I am a professor at UT Southwestern. I'm an otologist. I'm an ear, nose, throat doctor that specializes in ear medicine, and that includes hearing loss, surgical disease of the ear, as well as imbalance and ringing in the ear. So I want to give an overview of the auditory system, the vestibular system, tinnitus, and then I'm going to conclude my talk with the two papers Dr. Declava mentioned earlier, and just to go over those findings and help interpret those findings from the view of an otologist. So I have, these are my disclosures. None of these are relevant to this presentation. So I want to go over how the auditory system works. Initially, sound travels through the air through the ear canal, and this will contact the eardrum. The eardrum vibrates much like a drum head. This will then move the three ear bones. The third ear bone moves up and down like a piston, creates a fluid wave in the fluid-filled cochlea. There are specialized nerve cells that detect that fluid wave and then send nerve impulses to the brain. And this is going to be just an expanded or a magnified view of the tympanic membrane or the eardrum and the three ear bones. And this hearing through the air conduction is amplified because of the larger area of the tympanic membrane to the smaller area of what we call the foot plate. And so this gives the ear a gain of about 25 decibels. And in concerns with Havana syndrome, the conductive mechanism, this mechanism here would have really no particular relevance with Havana syndrome. But once we start looking at the cochlea, the cochlea looks like kind of like a snail shell. It's a 2.5 turns. This part of the cochlea is called the basal turn, and this is where the high frequency hearing will be located. And then as you turn around the cochlea to what we call the apical turn, this is going to be low frequencies. So this is actually going to be a frequency dependent on where the sound is located within the cochlea. And if you do a cross section of the cochlea, you can see there's 3 chambers. 2 of the chambers called the scala tympani and the scala vestibuli are fluid filled, and then the chamber called the scala media, and this is where all those specialized nerve endings are located. And this is going to be what we call the organ of Corti. And you can see this is a very intricate structure. It's pretty amazing how we're able to hear. In the organ of Corti, you have the outer hair cells, which are in rows of 3. And the outer hair cells are what are going to amplify the sound wave. And they're also going to give us that frequency specificity to allow us to enjoy music and to really understand speech and noise and these sort of issues. So oftentimes when patients lose hearing from noise-induced hearing loss or aging or hearing loss from medications, oftentimes they will knock out these outer hair cells. There's one row of inner hair cells, and these hair cells are what detect that fluid wave and then send the nerve impulses to the brain. So it's a very intricate system. The central nervous system and hearing has a very complex pathways that we understand fairly well, but there's a lot of questions we still don't understand. So once that fluid wave is detected in the cochlea, then the nerve impulses will go through a nerve called the cochlear nerve. That's one of the cranial nerves, and this will then synapse onto the cochlear nucleus, and a lot of these will cross over to the olivary nuclei, nuclear lateral lemniscus, inferior colliculi, and then medial geniculate body, and then they'll go into the auditory cortex. So you can see our hearing is very complex and can be really affected by many different ways, not just in the ear itself, but also through the central auditory pathway shown here. And so characteristics of the human auditory system, we're able to detect frequencies between about 20 and 20,000 hertz. And you can think of the basilar membrane that I showed earlier is much like kind of piano strings. And so where you have the higher frequencies, the basilar membrane is going to be shorter and stiffer, much like the piano strings would be in the higher pitched keys. And then as you go towards the apical turn, the basilar membrane is going to be longer and less stiff, much like here. So it's our cochlea is much like a piano in that's how we get that frequency specificity. And noise-induced trauma can create direct damage to the inner ear, as well as oxidative stress that can cause chemical reactions that could damage these structures. So after speaking about that, the question is, well, can normal auditory sound waves really explain what the victims of Havana syndrome are describing? Probably not. It's probably going to be something that's not going to be an audible sound wave. if an audible sound wave caused a lot of these symptoms, then it had to be extremely loud and heard by really anyone within, within many feet of the incident. So this takes us to radio frequency hearing, which is something I was not as familiar with. This is something we don't particularly think about clinically. This was first described by Alan Frey in 1961, and he reported that patients could audibly hear radio frequencies between 2.4 millihertz and 10,000 millihertz. And interestingly, the source could be tens of feet away, so it doesn't have to be directly next to the head. The loudest really depended on the peak power density, not the average. So this could be a pulse with a really high peak, and that's what could be heard as different kind of sounds that listeners described in this study in 1961: buzzing, clicking, hissing, chirping, knocking sounds that really aren't speech-like or would be real familiar sounds. And notably, the subjects in his study had to be in a quiet environment to hear the RF sounds, and they had to have intact high frequency hearing above 5,000 kilohertz. And in addition, the sound is typically heard behind, above the head, in the head, and one of the subjects reported hearing in one ear. So how would radio frequency hearing differ from our more natural hearing? Well, as I mentioned earlier, natural hearings, we're going to detect the sound waves. The ear is going to convert that into a fluid pressure wave, and then that's going to be detected by nerve endings that they're going to send the nerve impulse to the brain. Well, radio frequency hearing is thought to occur due to a thermoelastic expansion theory, where the radio frequencies will cause brief heating of the tissue. And this change in temperature can cause small pressure waves in the skull. And these would be very minuscule changes. But the cochlea is very sensitive, and perhaps the cochlea can detect those pressure waves through bone conduction, which we know that if you place sound on the skull, the cochlea can detect even normal sound. So it's potentially the cochlea can detect radio frequency hearing through this thermoelastic expansion theory. And so, it sounds like radio frequency hearing could explain the sounds heard by those affected in Havana and elsewhere, and these kind of clicking and these sort of sounds that aren't your typical daily sounds. So next, I'd like to talk about tinnitus. So tinnitus is the perception of sound without an external source. Oftentimes, when patients see me for tinnitus, they kind of point to their ear and they say, well, my ear's making a ringing sound or making a noise. And in reality, the tinnitus does not arise from the ear, but it's actually caused by defective input to that central auditory centers in the ear. And it's much like a phantom sensation. You may have heard of phantom limb pain, where someone may have a limb amputated, but they can still have their fingers burning, or they still feel that limb. Well, that's because those brain pathways are still intact, but the brain pathways aren't being stimulated, but so they sort of fill in this lack of stimulus with the sensation. And ringing of the ear or tinnitus is the same sort of phantom sensation, where I think of it as you have sound that is amputated, and then that sound is not coming into the central auditory system, and the brain kind of gives a sensation of ringing in the ear, or it could be, a roaring sound or a hissing sound. And that's how tinnitus works. And I've heard a term called ringing of the brain, which is probably a better description than ringing of the ear for tinnitus. So tinnitus is very, very common. And matter of fact, there's about 33 million Americans affected, and that's the same as the population of Texas and Oklahoma combined. And about 3 to 5 million of those patients will have severe tinnitus, where that's going to affect their daily living. It's going to affect sleep, and it could be very catastrophic for some patients. And matter of fact, tinnitus is the most common service-related disability for veterans, with about 42% of all veterans that have a service-related disability due to tinnitus. And that's most likely obviously due to the noise exposure during their service. So there's many causes of tinnitus. Almost the vast majority of patients with tinnitus will have some sort of hearing loss. Noise-induced hearing loss is a common cause of tinnitus, and that may be from military service, shooting guns, and other reasons and noise exposures. Ototoxic medications are less common. You may have heard that if you take high-dose aspirin, that can cause tinnitus. But if you look at most medications and you look at the insert, many medications will list tinnitus as a possible side effect. And that can occur with anxiolytics and medications to treat depression. And some of the medications, someone that with Havana Syndrome or other medical problems may be taking some of these medicines. Head trauma is also known to cause tinnitus, as well as depression and anxiety. Symptoms of patients, especially with more severe tinnitus, are going to be cognitive impairment. It can affect concentration. Insomnia is certainly a problem for patients with severe tinnitus. It can cause anxiety and stress and depression, just like many other chronic illnesses. And, oftentimes patients will ask, well, what is the treatment for tinnitus? It's really a treatment. A lot of the treatment now is really aimed at either treating anxiety and depression, which can occur with this, and along with the tinnitus. There's also other treatments such as cognitive behavioral therapy and tinnitus retraining therapy, and simply a hearing aid by increasing the amount of input into the brain can often improve the tinnitus symptoms. So finally, I'd like to talk about the vestibular system. The vestibular system could be thought of as having 3 semicircular canals, and these semicircular canals will detect angular acceleration. So the whole purpose of the vestibular system is for us to, or our brain to know where we are in space. And so when I turn my head in these different directions, my 3 semicircular canals, which are paired, are being activated to let my brain know where I am in space. And importantly, what I'm going to get to later, is there's 2 other organs called the utricle and the saccule, and together we can refer to these as the otolith organs. And these organs are responsible for detecting both translational motion back and forth, which would be the utricle, and then gravitational or up and down motion, and that would be the saccule. And so by combining all 5 of these inputs, our brain is able to know where our head is in the space. And if you have problems with these inputs or other inputs that I'll talk about later, that's going to cause that sensation of dizziness, which is a fairly vague term. It can be sort of felt different ways by different people. So this is the otolith organs here, and you can see the saccule here in this plane and the utricle. And again, the utricle is going to detect this translational or back and forth motion, and the saccule is going to detect up and down motion. And I'll get to the Hoffer paper from University of Miami, and they showed that all the initial victims that they were able to test had some defects in their otolith organs. So this is an important part of the vestibular system that may have been affected in these victims. But it's very important to know that the vestibular system, the ear is only a small part of the vestibular system. That's kind of the sensors of our head motion, but there's also important input from the eye. And, oftentimes I'll see a patient that may have some new onset of dizziness, and they'll report that they just, got new prescription glasses or maybe progressive glasses, and that's going to cause a sensation of dizziness or imbalance, foggy headedness and these sort of things. So the eye is a very important input. The brain itself, there's many central nervous system causes of imbalance and dizziness and vestibular problems. This could be concussion, traumatic brain injury. It could be multiple sclerosis. There's probably reasons we just don't quite understand in medicine why patients may have some of this. And also important is how we interact with the environment with our touch, and that's called proprioception. So as you can see in this bottom right picture, somebody walking along a path that's uneven, if they have poor nerve endings, maybe from diabetes, what we call neuropathy, then they're also going to have problems with ambulation. They're going to feel dizziness and unsteady. So it's a very complex system. Oftentimes you may have multiple problems in the system. So that's why it can be challenging to really make an accurate diagnosis in every patient with a vestibular problem. And I think that's why a multidisciplinary approach is very important. So I'd like to conclude my talk by discussing the 2 peer-reviewed publications and sort of my interpretation of these publications. Dr. Hoffer's at University of Miami, he saw the initial diplomats from Cuba within that first period of time, within the first 2 months, and Dr. Swanson at University of Pennsylvania saw these the same patients in about in a subacute to chronic setting. So this is a nice infogram showing the findings of the Hoffer paper. The diplomats in Cuba, they noticed a noise, a pressure, energy exposure. The vast majority, 92%, had ear pain and tinnitus, and then over half had cognitive complaints. On their findings, their physical exam was normal, which would be expected. The chair impulse test is where the patient is asked to look at the nose of the examiner, and quick head turns are performed. A normal subject will be able to keep their eyes focused on the nose, but someone that may have a problem with the vestibular system are going to have a difficult time keeping their eyes focused on the nose. This shows the laboratory testing, and the C and OVIB and the subjective visual vertical test, which I'll explain in a moment. They were abnormal in 100% of patients. And their theory is that these diplomats had some sort of damage to those otolith organs. Again, the organs that allow us to understand we're moving forward and back and up and down. And that was their theory on why these patients may have had, especially the vestibular symptoms. And this is just showing from the Hoffer paper, over 90% of patients had dizziness, and the majority of patients had cognitive complaints. Hearing loss, tinnitus, ear pain were less frequent, but they were also noted in a significant amount of patients. And interesting, only about 25% of the patients complained of headaches, which I'll mention later. And Dr. Hoffer, who is an expert at traumatic brain injury, thought that was a fairly low number if this was truly a traumatic brain injury type of injury. The characteristics of the sound heard by the victims, the sound was very loud. It was high frequency. It was very localized. And some of the victims, they noticed they walked to different parts of the room, the sound may get louder or even go away. And importantly, a few of the victims, when they walked outside of the room, the sound went away. And so there's been some theory that maybe cricket sounds were heard by some of the diplomats, but this makes that less likely, at least for these diplomats. When they went outside, there was no noise to be heard. So these are the objective findings through the vestibular testing. The visual vertical test is where the patient wear goggles, everything's blacked out, and there'll be a line they're trying to they're actually trying to turn that line to a vertical position. And about 90% of the patients fell without what we call within norm, and they would not be able to quite line up that vertical line vertically. The OVIMP and CVIMP are tests looking at the saccule and the utricle, and these are abnormal in about 70% of patients. Interesting, most of the patients did not have abnormal audiometry. There were a couple that did, but that's difficult to interpret since we didn't have any sort of hearing test before they were evaluated. This is showing the subjective visual vertical test. Again, that's the test where the patient's trying to make that line in a vertical manner. Historical controls, most people are able to do that quite well, but the diplomats had a more difficult time doing this with an error much greater than we'd seen in historical controls. Another test they did was an anti-saccade test, and this is where looking through the same goggles, a light will maybe go to the left, and they're asked to actually move their eyes in the opposite direction. And this is a test of frontal lobe function. This was also found to be significantly abnormal in the diplomats from Havana. So some conclusions on the Miami report. The perceived sounds disappeared and the diplomats opened their door, making insect sounds, unlikely to be the auditory source. Not all heard sounds. And, again, as we know from Dr. Frey's work, to hear the radio frequency sounds, it needs to be in a quiet environment, and the person hearing the sounds would need to have intact high frequency hearing. Vestibular test has suggested injury to the otolith vestibular organs, and this was seen in 100% of the diplomats. Most did present with some cognitive impairment, and the findings are different than what we'd see in classic traumatic brain injury. And this, in traumatic brain injury, you typically wouldn't see the problems with the subjective visual vertical test. There was a low incidence of headaches in these diplomats, and then there's abnormal otolith testing. So whether this isn't really classic TBI, maybe there's TBI with these abnormalities as a possibility. Next, I'd like to conclude by looking through Dr. Swanson's report, and notably the patients at this point were then seen at a subacute and chronic period of time, a mean of 203 days. Dr. Hoffer saw all of them within 2 months. This is a multidisciplinary workup: physical medicine and rehabilitation, occupational medicine. And this is a clinical evaluation. And someone had a question, and both of these were just clinical evaluations. There were no protocols or anything of that sort set, which may be something that will be possible in the future from what we know now. So the characteristics of the exposure, the victims heard directional, sustained sounds, buzzing, grinding, piercing. 43% felt a pressure sensation, kind of like air baffling when you have your windows down in a car. The stimuli were directional, and about half of them thought that the direction was a very precise location, and the sensation lasted between 10 seconds and over 30 minutes. Subjective findings, and again, these are findings that are going to be later, up to around 200 days out. They have many of the diplomats have sleep problems. They have complaint of visual issues, cognitive disabilities, and their headaches were actually more common as time progressed, with about almost 80% of patients having headaches. Also, there seemed to be more auditory and hearing loss, although it's difficult to assess this without having a prior hearing test. This is just the objective findings from multiple testing, and the majority of the diplomats had vestibular, cognitive, and oculomotor issues. This is just their table, and just showing, especially looking at the balance and vestibular. 71% still complained of balance and dizziness problems. There were still objective findings with problems with the vestibular ocular reflex and balance issues that were detected by testing. So to conclude on the University of Penn report, they were audible sounds, like I mentioned earlier, really not known to cause any sort of persistent nervous system injury. They can cause hearing loss and tinnitus, but a lot of the complaints of the victims or the diplomats couldn't really be explained by just an auditory stimulus alone. And they also thought several of the objective measures, such as the oculomotor and vestibular findings that were seen on testing, could really not have been manipulated. And they also concluded these findings are not consistent with a classic concussion or traumatic brain injury. So in conclusion, auditory sound waves probably would not have caused these symptoms. Perhaps radio frequency can explain the symptoms through the Frey effect, especially the sounds that the diplomats heard. Hoffer demonstrated objective vestibular abnormalities in really all the diplomats, and especially felt that the otolith organs seemed to be damaged in 100% of the patients, or at least were abnormal on testing. And then Swanson, looking at more of the subacute and chronic findings, also showed ongoing cognitive, vestibular, and auditory complaints. There are many, many unanswered questions from the diplomats in Havana, and also other people from around the world that have had similar sort of symptoms. And I think, having a conference and discussion like this will hopefully really improve our understanding. With that, I'm going to conclude my talk, and I know there's going to be many questions. I try to leave a few minutes, so I will go through the questions here.
Dr. Kutz, yeah, I can read the question, and then
okay, that'd be great.
We have several questions from patients that are civilian who are asking if they have Havana syndrome. And as I pointed out, Havana syndrome is a descriptive term, not a diagnosis. But for patients who feel they have vestibular complaints, if you could give a brief answer as to the best place for them to start to get treatment wherever they're located.
Yeah, I mean, I think, like you said, Dr. Decleve, seeing an academic medical center that really, I think a multidisciplinary approach is best. In our practice, patients with vestibular complaints will either come in to see me, or maybe you, Dr. Decleve, or Dr. Bay, or one of our neurologists, UT Southwestern, and then we're going to get a history. We're going to do some directed testing, in some cases, maybe imaging, and then oftentimes we're going to refer our patient to one of our colleagues that are better suited to treat what we think is going on. And frankly, many patients with vestibular complaints, the diagnosis is very difficult, even for the most experienced of teams. And I think that's one thing patients need to understand is, the teams are certainly do the best they can to diagnose what's going on. And I just think there's many things in medicine, even in 2022, we don't understand. But I think starting with a university, or at least a multidisciplinary type of program, would be best.
Outstanding. We have another question from Dr. Eric Hazeltine, who is with Psychology Today. And he asks, does directionality imply unequal radio frequency amplitude on opposite sides of the head? I don't know if that's a question you can answer.
Yeah, I'm not an expert at radio frequency hearing. It's a great question. I'm not an expert to answer that.
Robert McCrade has another question. He thanks you for your presentation. And he asked if you or Dr. Balaban in the Miami study, is there any agreement on these issues and determination of the most likely avenue of cochlear insult among anomalous health incident victims? Can it be attributed to nanopulsed radio frequency or mixed RF plus acoustic waves? And does the Russian research suggest, is there any other work you're aware of in terms of thermal targeting on the basilar membrane or otoliths, as you discussed?
Yeah, I'm not aware of that. I think there's a lot of questions to be answered. I think there's probably people more specialized in that sort of research that may have a little more insight. I think the thermal elastic theory was interesting, that there may be a very slight thermal heating of the tissue that can cause bone conduction, and the cochlea can pick up that small, changes in the bone conduction. And maybe that's what, giving the victim the sensation of a sound. But I don't know the answer to the exact physics. I'm not sure anybody knows that. I think that's still things that need to be studied.
Okay. I'm looking at other questions similar. I tried to pick a question. There's several along the same themes of radio frequencies. And again, you answered the question about civilian patients, how to best start. Okay. We'll wait a few minutes for any other question. Can you comment? I have a question that indirectly has come up. Can you comment, Dr. Kutz, on the neuroradiology findings and what they may mean in terms of the Swanson, the 2019 UPenn study where they showed structural changes and DTI changes?
Yeah, I would defer that to my neurology colleagues. This is kind of why the multidisciplinary approach works well. That a lot of those very high level brain imaging, I don't use in my practice as much, but I think maybe our neurology colleagues could comment on that more effectively than I could.
We'll leave that to Dr. Bay then. There's another question. Are there ongoing follow-ups for the diplomats with chronic exposure? I can help you with that one. The answer is yes. There are ongoing studies at Walter Reed, and there's an ongoing 5-year study still in progress at the NIH, which is a TBI study. And they're trying to develop standardized screening forms for diplomatic personnel overseas who typically present to a primary care setting in one of 250 health units around the world in the embassies and consulates, so that primary care clinicians, nurse practitioners, nurses, and physicians can screen them appropriately. There's a question from a patient, where can they go in the Houston or Dallas area? I'm assuming UT Southwestern. Can you, for someone in Houston, do you know of any centers that specialize in ENT that do what you do in Houston?
Yeah, I actually trained at Baylor College of Medicine, Houston. It's an excellent medical center, and they have experts in psychiatry, otolaryngology, neurology. So I think in Houston, that's where I would start.
Okay. Okay, I think thank you very much for your outstanding presentation, Dr. Kutz. You left your email on the last slide. If people have questions, they can either email me directly at kenneth.dekleva@utsouthwestern.edu or Dr. Kutz at walter.kutz@utsouthwestern.edu, and we'll do our best to answer those questions.